I'm Dr. Ross Melvin. I'm coming to you from New Cardiovascular Horizons digital education series. Today, I'm going to be talking about the use of CO2 angiography in application to peripheral intervention. I'd like to thank Dr. Walker for having me and acting as my mentor over the last year. As a little bit of my background, I'm a interventional cardiologist. Came down for a year fellowship with Dr. Walker and trained under him and saw some amazing things. And now I am a partner with Cardiovascular Institute of the South. And he was gracious enough to let me speak at this digital education series. So to get going, induced nephropathy at what cost is going to be the title of my presentation. I have no disclosures. So just quick basic definition of CIN. It's defined as a rise in creatinine of 0.5 milligrams per deciliter above the patient's baseline, or a creatinine increase of 25% above the patient's baseline. Then utilizing contrast media when we're performing intervention is quite common. Unfortunately, it leads to a slew of issues with the patients, incurring greater hospital stays, incurring greater hospital costs, increasing mortality, morbidity, all things that as interventionalists we should be very keen on trying to limit or even eliminate if possible. And just looking at different figures, your average cost of in-hospital stay is around $10,000. That can be increased up to, from this report, up to 11, nearly 12,000, just based on, these running into these issues with contrast-induced nephropathy. The only absolute prevention at this point in time is to avoid contrast. I know for a lot of patients, we have algorithms that we follow to hydrate them pre and post procedure. And then there's been other agents that have been tried to reduce CIN in the past, but really the only tried and true method is to limit the amount of contrast used during the procedure. So looking at sort of a prediction score for a risk factor score for patients that could be introduced to or could get CIN as a result of use of contrast in the procedure. You look at different risk factors, and typically the patients that we're going to be seeing, the majority of them, are going to be older patients. They're going to be greater than 75 years of age. A lot of them are going to have, other cardiac risk factors like diabetes, hypertension, hyperlipidemia. A lot of them are going to have heart failure. So that alone, the general population we're going to be looking at are already at pretty increased risk. Most of them are going to be at that 1% risk of getting CIN based on this prediction score. In addition to that, if they do have some baseline chronic kidney disease, it puts them to almost that 12% risk that you see in the corner. So, limiting these patients die is of the utmost importance when we're intervening upon them. And with the patients typically becoming older and older with better medications and interventions, CIN is going to be becoming more and more of an issue. So just keeping these risk factors in mind when you're seeing patients and sort of delineating whether or not, can I get away with CO2 angiography? Should I use dye, or can I use a mixture of both to help lessen the risk of CIN in your patients? I think is a good thing to do. So as we sort of talked about before, CIN is increasing in PAD. Diabetes is an epidemic, so that's going to be a risk factor that you're going to see quite frequently. There's more peripheral interventions being performed, more limb salvage with the new, with our newer wires, newer crossing catheters, reentry devices, newer balloons and stents, etc. We're able to perform very complex intervention on more and more patients. So that's opening up more avenues to recruit more patients to do percutaneous intervention, but also that can lead to more cases of CIN as PAD grows. if we're not utilizing other modalities other than contrast to treat these patients or to diagnose these patients. So just real briefly, I touched upon other modalities other than contrast. As I said before, I just want to hammer home that really the only way to avoid CIN is to limit the amount of contrast that you use. Now there's multiple different methods that you can use in the lab to try to limit contrast. Ultrasound guidance is an obvious one, and OCT can be utilized as well to limit the dye. But specifically, I'm going to touch on CO2 angiography. And with that, obviously, there's no renal impairment by using CO2. There's no really limit, dye limit. You don't have to worry about that. So you can shoot pictures as many times as you want to. Obviously, you want to conserve radiation, but as far as causing CIN, there should be no limit on the amount of CO2 that you can use. And also you can get better pictures, I think, as a result, because you can use oblique angles or you can zoom up. So I think that's a definite benefit of using CO2. Additionally, concerning hospital stays, if you're going to use CO2 in patients that are high risk for CIN, you don't have to admit them early for hydration. You don't have to keep them later for a prolonged stay of hydration, or worst case scenario, they start having renal issues and have to stay in the hospital as a result. And additionally, it's either to inject CO2, so you can use smaller 018 catheters, to help image if needed. So just a brief history on CO2 angiography. Carbon dioxide was first used in 1914 by radiologists to evaluate different spaces in the human body. It wasn't until the 70s that it was used intra-arterially to diagnose PAD. And the reason that they used it in Florida was because of a contrast allergy. So that was something that I'll speak on a little bit later, but patients with contrast allergies, we often utilize CO2 in the lab because we don't have to pre-medicate these people and we don't have to worry about a reaction. Moving forward with the history, in the 1980s, the advent of DSA, or digital subtraction imaging, became much more reliable and thus was able to be used with CO2. So now that we can get very crisp imaging with the CO2, almost very comparable to the imaging that we get with the different contrast medias that we use. So why would you consider using CO2? Obvious one, and really the whole purpose of this talk is avoiding contrast-induced nephropathy. I spoke a little bit earlier about avoiding severe allergic response. I've seen a couple patients that, they have deathly anaphylactic reactions to dye, so they can't get any dye. So if they have PAD and you want to intervene on it, you have to find other modalities to use. And oftentimes, with multiple patients, I've seen this, and we've used CO2 to repair these, to intervene on these peripheral arterial disease. Like I talked about earlier, there's a lower viscosity, so you can use smaller, longer catheters to inject through, which might be, you'll be more limited with the more viscous contrast medias that we use. And also, occasionally, contrast isn't as good at visualizing the peripheral arterial disease. What I mean by that is there's been instances where, by contrast angiography, it looks like the lesion is a short CTO or a long CTO. We go in there with CO2 and we're able to inject it, and the CO2 is less viscous and it's able to travel down sort of micro channels that you can't see with contrast media, which proves that, one, it's not a chronic total occlusion, but two, also gives you an idea where those micro channels are, and allows you to approach them with a wire, I think, a little bit easier. And then as far as hospital expenses, it is less expensive to use CO2 as compared to contrast medias. And also, the biggest thing is to avoid the indirect costs that can be incurred if you put a patient into CIN. That obviously they'd stay longer, medications, potentially, worst case scenario, dialysis, but it does happen, unfortunately. But switching to CO2 can minimize some of these risk factors. So drawbacks of CO2, honestly, they're few and far between, but there are some reports of non-occlusive mesenteric ischemia. Reports of this are rare. We'll use this, pretty frequently at CIS in our lab to image renal arteries and even up into the iliacs too, in the aorta. I've never run into any cases where you get mesenteric ischemia. However, I think it's a pretty easy fix if they actually do get a good injection into the mesenteric artery and they haven't becoming symptomatic. It's just a simple position change to relieve that air, and that should resolve the issue. Can't use it for intracranial imaging. Can't use it for cardiac imaging because it's a DSA imaging, and obviously the patient would need to hold still during the imaging, and obviously a heart can't do that. So unfortunately, at this point in time, those are two spaces that we can't use CO2 angiography. Otherwise, it's a great modality. And I have a couple cases that I'm going to show you towards the end of my lecture that sort of give you an idea of what we're looking at with CO2 angiography if you haven't had any exposure to it in the past. So optimizing this imaging, this part is crucial. The DSA imaging, you need a lab that's set up to do that. Otherwise, you're not going to be able to see anything very well with the CO2 imaging. Obviously, you're going to need a patient that's compliant and able to hold still with this imaging as well, because if they move with the DSA imaging, you won't get clear images. You won't be able to see anything. Additionally, you got to make sure that you're close to the stenosis that you're trying to image. The closer you are, the better, because CO2 dissipates so quickly in the bloodstream that you need to be real close to the stenosis to get adequate views of it. To do this, it's just a slow, constant pressure injection. And then there's different positional movements, like I talked about earlier, to optimize the imaging. If they have bowel gas, you can move them around. Even lifting their legs sometimes can help with improving the imaging, the CO2 imaging in the lower extremities. And you might ask, so, what's the correlation between contrast media and CO2? Is it comparable? And in a study by Seeger, 92% of the cases were comparable to the use of contrast medias. And even if they sort of did a hybrid approach where they used CO2 and a little bit of contrast later, that correlated with you could see just as well, and were able to perform the interventions just as well as using 100% contrast. So to qualm any reservations about using this, the imaging, if used appropriately, and we talked about that earlier, is just as good as any contrast media that you might run into.
Is it on?
And then,
okay, so this is the CO2 Commander. It's the injector.
So this is just a sort of, I'll give you an idea of what it looks like, how we use it in the lab. This was taped actually in Detroit during my interventional fellowship with Dr. Sushruth Edla on the right and the great Ted Schreiber on the left. So this is a quick 30-second preview, sort of just give you an idea of how we use it in the lab.
Device for the CO2 angiography. Basically, you have a little cartridge here that holds the CO2 so you can get multiple injections. There's a knob here to adjust how much CO2 is being filled into the cc syringe, how many cc, 60 cc syringe. And then you hit this little red button, and this tube is hooked up to this syringe, and it fills up the syringe. And then you just sort of toggle over to fill up the second 20 cc syringe. So that's how many cc's or 30 cc syringe. That's how many cc's are using each injection. And then you toggle over to the patient, open, and administer the CO2.
Okay, so this whole system it's there to protect the patient. It's making sure that you're not injecting directly from the CO2 Commander at at high pressures. So this toggle system allows you to, if you look at the picture on the left, it allows you to toggle over. So you're just projecting with your own hand power, or injecting with your own hand power, as opposed to just coming directly from the machine, which makes sure you're not causing any trauma to the vessels as you're injecting the CO2. So advantages of using the Commander: small, compact. As you saw, it was easily held in a sleeve. And you don't need the actual whole setup. You can just lay it on the table if you have a sleeve for that. We often do that in the lab here. Easy to operate. Once you've seen it done, it's like sort of see one, do one, teach one. And like we talked about, that K valve acts as a safety mechanism. So you're not perforating any vessels by directly injecting into the patient from the device. So that's about that. So this first case, I'm going to just move on to, I got two cases for you. This first one, you can obviously see that this is a heavily calcified vessel. Just by fluoroscopy, you can follow the SFA down to the pop, down to the infrapopliteals. And this was a patient that was brought to us for a short CTO of the SFA. So this is what CO2 angiography will look like for those who haven't been exposed to it earlier. Instead of a black, it's going to be more of a white color. Now there is a way that you can mess around with the camera if you really want it to be black, and you can switch it to that color. But I think black or white, you can still obviously see. The SFA is pretty well delineated with the CO2 gas, and you see the short, what was called CTO by previous contrast angiography. And we took a small 018 quick cross catheter. It's probably 035 quick cross catheter down there, and we're injecting around that, and you can actually see the microchannel that was the previous CTO, which allowed us to wire it a little bit easier. So this is one of those cases that I was talking about where the contrast media didn't find the microchannel, but the CO2 was advantageous in this because it gave us an idea of the microchannel that we needed to wire to get down the vessel. So after we were able to wire it, we performed laser atherectomy, balloon angioplasty. There was some stenting done that I just cut out, and this is our result post, which you see there's no residual stenosis there. And then flow down into the popliteal. And then the second case is just, a lot of times, because this dye will dissipate, or not dye, but excuse me, the CO2 will dissipate quickly into the bloodstream. A lot of people will be hesitant to use CO2 below the knee. But you can get good imaging as seen here. We see the common femoral down into the SFA here in profunda. And this is all from being shot from the CFA. So you see down into the popliteal, getting into the bifurcation of the infrapopliteals. So you see they have bad infrapop disease. And then even down into the ankle, you can see, there's still evidence that there's flow down there. Now, like talked about earlier, if you want to get improved imaging, you want to take some sort of catheter down to the level of the popliteal, and you can inject from there, and your CO2 images will be much, much improved. You'll be able to delineate the vasculature much better. And at this point, if you're still not seeing it well, you can try to mix CO2 and contrast media. You've still saved the patient, a significant amount of contrast by initially starting with CO2 imaging. So just touching base for an injection technique for CO2 angiography. When you're performing this imaging, you have to make sure between each injection that you're giving the patient some nitro, giving the patient some saline flush to try to flush out the CO2 as much as possible. If you don't do this, you're not going to get good imaging down the leg. And a lot of the times the CO2 won't really propagate down further. So you really want to make sure that you're flushing out between injections. And we found that to help with the imaging, especially below the knee. So just moving on, CO2 in general, I think has changed. It definitely has changed how we practice here at CIS. We've been able to take on much more difficult, complex cases in patients with chronic kidney disease, in patients with severe contrast allergies. It's cut down on our pre-admission hydration, the pre-admission allergy medications that we need to use. And like I said, has dramatically increased the number of patients we're able to intervene on successfully and avoid complications with. So in summary, CIN increases acute and long-term morbidity and mortality. 1. 2, CIN increases acute and long-term costs. 3, CIN is strongly associated with independent risk factors that should be avoided. And obviously, we want to avoid any complications, including CIN, at all costs. So I would urge you, if you're not already, to sort of limit the amount of dye you're using, to utilize modalities like ultrasound, like OCT, and like CO2. Because in the long run, it's going to help your patients, it's going to help your practice, it's going to help offset costs for the patients, it's going to help offset costs for the hospital, for your OBL, wherever you go. So I think by utilizing this in your practice on a regular basis is beneficial for everyone all around, for hospital systems, for patients, for doctors, for staff, whoever it is, it's beneficial. So I would urge you, if you're not already, to take into consideration using it. And if you are using it, then I think you're progressing with the interventionalists and how the future landscape looks for vascular intervention. So on that note, I'd like to thank Dr. Walker for having me talk for NCVH. I'd like to thank Tom Best for helping me out, setting this up. And I think you'd be able to, if need be, I would contact NCVH and they can give you an email address if you have any questions about CO2 utilization or vascular intervention in general. And I'd like to thank you for your time.